name's Jake Klein. I am a pediatric nurse practitioner. I work for OKC Kids Urology. My attending physician is Dr. Brad Kropp. We've been in practice together about 20 years. We did about 6 to 8 of those last summer, and about six of those this summer, reconstructive surgery. And the indications for reconstructive surgery is usually going to have to do with some type of neurogenic bladder or neurogenic bowel presentation. A lot of these kids will have bladders that are acontractile. They may not squeeze. Some of the bladders may not grow and be appropriate for age. You have to have two things to be dry. You have to have bladder size that's age appropriate, and you have to have bladder neck resistance, a tight enough bladder neck to hold the urine in and be continent. And so these are areas that we assess with our history and our exams as we take care of these kids over the years. We do video urodynamics, which gives us a very detailed assessment of the bladder. It lets us know bladder capacity, more importantly bladder pressures, which is what we describe as bladder compliance. And so think of a balloon that stretches up very easy. That's a nicely compliant balloon or a compliant bladder. There's also balloons that are very tight that don't stretch. That's one of the indications for the surgeries, is a lot of these kids develop very tight, kind of what we call high-risk neurogenic bladders. Their pressures get very high, and those high pressures in the bladder can then be diverted to the kidneys, which can create problems such as hydronephrosis, which is a collection of fluid on the kidney, vesicoureteral reflux, which is abnormal backwash of urine up to the kidneys from the bladder, and they need more size and a safer bladder. Many of them don't have good bladder neck resistance. We have a bunch of different diagnoses that present with problems with the sphincter mechanism that holds the urine in, and so a lot of them need some type of bladder neck, either a sling or tightening or even a ligation where we close them off because they're too wide open. And then we can create other avenues for them to manage the bladder, which would be catheterizable stomas, so that they can empty the bladder instead of having to catheterize below. They can catheterize through a stoma. And then also many of them have associated neurogenic bowel, so they don't have predictable bowel movements. They have slow transit time, constipation problems, fecal soiling, and as that progresses through the lifespan, it becomes very problematic for the kids when they're getting ready to start school, because social continence moves up on the priority list, both urinary and fecal. And so most of the children that are getting these reconstructions usually around school age, or sometimes a little bit later, just depending on when the family and the child are ready to proceed. And that's really the indications why we do them. Is what we have 3 goals in pediatric urology. Number 1 is to preserve the function of the kidneys at all costs. A lot of our focus is on that as they're young, as they're infants. As they grow, continence becomes the second goal to obtain, both urinary and fecal continence. And then the third goal is independence, and that's being able to teach the child how to better understand what has been reconstructed and how do I manage it and how do I make it work for myself as I get older, and the parents begin to pass the torch and transition some of that care. And so those are the reasons that we do all these big time surgeries.